So the previous speaker said the first line of care is ITZO, so I think we'll have to differ. This is a sponsored session, and that is my disclaimer. So thank you, esteemed panelists. So a very new slide set. I think most of us have seen it umpteen of times. So the patient is a 62-year-old heavy smoker, came to us with breathlessness, hemoptysis, weight loss, early satiety, massive liver enlargement on examination, and a CT scan shows a left lower nodule with mediastinal adenopathy, massive hepatomegaly. Biopsy was done from the liver, which showed a SCLC histopathology. So, what is the diagnostic workup? Anyone who concurs with this or who feels this is wrong? Sir, open for the panel.
So definitely biopsy is needed. Even FNAC is actually okay for small cell if the pathologist is like confident enough.
We don't have a pathologist here, no? No. Okay. All of us are medical oncologists. Yes.
Bronchoscopy, I don't think if it is needed if it is a clear-cut metastatic disease.
Okay.
PET scan, definitely even if CT scan is also okay. Brain MRI, I get it done in all patients.
Thank you. Sir?
Yes, I agree. PET CT plus MRI, this is usually we do in all patients. And image-guided biopsy, we usually rely more on biopsy. Others, if we are not able to access.
So we don't have to do the primary biopsy. We already have it from the metastatic side. So a metastatic side biopsy with a PET CT and MRI brain is something which both of you are saying. Sir, anything else?
I also agree with the same.
That correct. Perfect. Same. Okay. FNAC? Anyone is happy going ahead with only FNAC or biopsy is a must?
I think
because most of our pathologists will give on a FNAC, SCLC.
Yeah, most of the time we do biopsy, but if someone comes with FNAC report of SCLC and pathologist is quite confident, I think we can go ahead if it matches the history of clinical features.
Okay, our pathologists are coming in. That is a very good. So, ma'am, we were discussing that in a small cell lung cancer, will all of us as medical oncologists, ma'am, anything you want to add? Yeah.
If I would be working up on the case, I would first choose a biopsy. But if he's already come with a cytology report,
you will not go ahead with a biopsy.
If the PET is already revealing that it's matching with the symptoms, I'd be okay with it.
Okay. Ma'am, we are discussing that we have a case of small cell lung cancer. So someone has done a biopsy or FNAC from the liver. We are happy that a PET CT and MRI brain is done. So in a small cell lung cancer, a FNAC, most of the pathologists will tell us as clear-cut SCLC. Will you like to shed some light on the sub-classification, those new AIN, AAC and all those things you are doing on the lung cancer, small cell lung cancer, these recent things? No, upfront. Okay. And something on those subtypes of SCLC, the recent subtypes? Not come, but you are doing a lot of work on this, especially the AINC.
Yes, correct.
AINC.
So we'll have to do it individually. Even I have never done it with the.
Sir, yes.
3% incidence of EGFR positivity.
Yes, that is also.
Correct.
So some recent data which has come is these AIN classification small cell. And I think RGCI, tomorrow Dr. Last will be here. They are saying that AINC subtype, the chances of immunotherapy working is much higher than the other subtypes. But still, we are all working on FNAC. I myself will agree on that. Okay, so happy with the FNAC or a biopsy, whichever is from the metastatic side, PET CT, and a MRI brain for a brain. Correct. So this is what the NCCN says. This is what our biopsy patients showed. So this was an extensive stage small cell lung cancer with a liver metastasis. So how will we treat? Sir, chemo, which chemo? Anywhere, please.
Yeah, so if it is extensive stage for palliative treatment, my generally choice is carboplatin with etoposide. And if the patient is affording definitely immunotherapy, I will add here.
From first cycle or from second cycle? Or any other choice you have?
patient is not trying tumor lysis, we can definitely add in the first cycle itself. And one thing about cis versus carbo is that
Yes,
efficacy-
you know the questions in this slide set.
So the question is not about which one is better. It is that which one is more tolerated well in this scenario. If patient is GFR is good, I usually prefer cisplatin because that doesn't cause so much of myelosuppression. However, with carbo, the problem is that with third and fourth cycle, myelosuppression becomes a problem.
And the reactions with subsequent cycle of carboplatin. True.
So cisplatin.
And I think our training also, we are being tuned that cisplatin is a better drug, cisplatin is more tolerable. I think that also.
Yeah,
Sir,
but in a small cell, there is
both
not
are
much
equal.
difference.
True. Sir.
Other points are sometimes these patients are in an emergency like HPCO. That time you would need rapid response. So I think we prefer cisplatin over carboplatin for that rapid response.
Cisplatin will give response by second or third day. Carboplatin will take 3 to 4 days.
True.
It's a small difference. That is
But
what we have
again, if you
observed.
have a tumor lysis like condition, kidney will again be something you are bothered about. So there the rapid response versus nephrotoxicity.
In real practice, most of the time we have to utilize AUC2 carbo day 1.
Yeah, that time I think single agent carbo is something, AUC, like he said, AUC2 carbo is something which you are more bothered about. Sir.
So I generally give carboplatin for 4 to 6 cycles, most of the time 6 cycles, and
Keto carbo.
carbo. And I do add immunotherapy if patient is affording.
Any choice of immunotherapy?
So I am happy with either of them based on the finances and PEP available.
I think both have similar
Largely
finances.
similar
If we
PEP.
disc
With PEP largely.
with
it is
PAP
similar.
largely the same.
Yeah, and for the third questions, there is some data that even Irene they have similar
Japanese
response rate
data.
and we can be used. But it is we are too comfortable with keto
yeah.
carbo.
Yeah, so in a palliative setting, a lot would depend on the performance status of the patient also, and also the age of the patient. So if the patient is cisplatin eligible, I have found our patients, we are from the northeast part of India.
Yes, ma'am.
So generally, they do tolerate cisplatin quite well, and especially if we divide it into, 25 milligram per meter scale for 3 days. We've seen a better tolerance. So if they are cisplatin eligible, I choose cisplatin. Otherwise, carboplatin AUC5 is a good choice. And regarding adding the third drug, of course, that would depend on the affordability. Ours is a government setup, so it's our patients are from really poor socioeconomic background. So it's a challenging situation for that.
Ma'am, I may ask you, why are we thinking about cisplatin eligible versus carboplatin? Do we think the response rates will differ?
We've generally seen that the tolerance to cisplatin, we don't see that much of toxicity because cisplatin is widely used as a chemotherapy for various other cancers.
True.
So generally,
In lung specifically, if we talk about the VLSG studies and the other, they have clearly shows that in lung per se, cis versus carbo, there is no survival or PFS difference. They have been clearly showed in a large trials. Other than that, or either personal choice. So
I would say that we need more data from our part of the region because our patients, they are culturally, structurally, geographically, socially from a very the different biology could be playing.
Okay.
So that is something that we are interested in looking into.
Sir, you want to add on something?
Immunotherapy data means like durvalumab has allowed carbo and cis both.
Yes,
And
that
additionally
is
we
the
have data
difference.
with cisplatin only.
That is
So in that case,
no, we were just talking without the immunotherapy because ma'am was talking about a government setup. Okay, coming on. Okay, so this we have clearly done. I think. So this we have clearly done. I think in all patients where the finances are not a problem, we'll definitely be adding some sort of immunotherapy. And choice, I think, will be either of the thing. Any bias to the choice? So, open house. Which do we prefer? Personally.
anyone, whichever is cheaper.
Cheapest, I think cheaper wise, if you discuss all the immunotherapies with the PAP, you will not have a difference of more than 5,000 to 6,000.
So maybe Durva then.
Durva, you. Good.
Because some of the factors.
No, factors, I'm just asking a personal choice. I will not ask this. This is my job to come to the factors.
The trial was conducted in a much better way for Durva.
Okay, so they were smarter with the trial.
And also the maintenance treatment of
Durva is easier, 28 days. True.
Maybe I'll For me, either I can choose. I'm not biased for anyone.
No, what you have been using. I'm just asking your
We
clinical
are-
practice. I'm not asking you to choose.
Both we are using, sir. Either Durval
So
or
you are giving both them equal share. Correct. Absolutely correct. Sir, ma'am has clearly come out. She is saying we are in a government setup. I'll not use either of the two.
So,
won't say we won't use.
Okay.
If our government, because we
Government
use some-
buys, then whatever the
then
L1 will be there. True.
so even in private setup, the population which we are considering is less than 5%.
No, I'm just asking
Yeah,
whatever
so
you are
in-
using. I'm not asking anything else.
So I've been using both.
Both.
And
True.
as Dr. Samir and Dr. Akhil told that the design was more practical with durvalumab.
So
and
most of
the,
us.
maintenance strategy was more feasible.
Okay. So I'll say that Durva was more smart with the trial design than ETI here in this particular setting. Okay. So these are there. We all know that the earlier we use immunotherapy, at least in small cell, has taught us that better outcomes, preferred regimen, all of this, most of them say. So we have already discussed this. What are the considering? I'll just skip this because we have a very big oration and I'm already getting late for the oration. This all. So the only thing about Durva which favors is they have a 3-year data, OS data, which ETI has not yet released, and maybe ETI will be releasing this year in ASCO, the 4 to 5-year data. Then the competition will be more head-on. And I think one thing which clearly the younger oncologists will feel is when we were starting the small lung cancer clinic, we were sometimes told to ask the consultant before enrolling any small cell lung cancer patients, which has now changed because of these newer molecules, because the survivals have, or the PFS at least have improved in small cell lung cancer thanks to these drugs. So, last 2 questions and I'm winding up. Sir is showing me eyes. So, PCI in DEP patients, comments, yes or no? With such good drugs, with immunotherapy drugs, DEP regimen, will you give PCI and thoracic RT? Yes, no, yes, no.
So if the response is good, if they show very good complete response.
One more question. And all the talk about episcopal effects, sir, very senior radiation oncologists are here. When immunotherapy came in non-small cell cancer, they taught us that there is something called as episcopal effect. Lungs will go away, patient will go on ventilators. So with that in mind, answer.
Okay, well, basically, if the patient has shown good response to chemotherapy and there is a good systemic control, then PCI is definitely going to be offered to the
And
patient.
thoracic RT,
And
patient
even
has got a very
thoracic
good.
RT, if the systemic control is good, then the and
Patient
even if
has
there's
got
a PR.
patient has got a near CR, a very less measurable
Yes.
disease. So you will give
even
both.
thoracic RT.
Okay. And continue durvalumab maintenance.
Yeah. I mean,
Okay.
if the patient can afford it, then yes.
Patient is affording, madam. We are here discussing affording.
So PCI, yes, surveillance is difficult in most our patients. They are not as compliant as it is in trial. For thoracic RT with IO, I would avoid giving thoracic RT. I am afraid of pneumonitis and then discerning whether it is radiation induced or IO induced. And if patient is not taking IO, then I would refer
Patient is
for
taking
thoracic
IO.
RT. Then I will not.
So you will give PCI and
But
avoid
not-
thoracic RT.
For me also, if patient is either PR or CR, I'll consider PCI. And depending upon if IO, I'll try to defer the thoracic RT.
RT.
Completely agree. Same.
Same.
If IO feasible, avoid RT to thorax at least.
Very old patients with cognitive impairment, then
PCI also you like to defer. True. So anything else?
Absolutely fine. Only thing is that generally SCLC patient will have central tumor other than the peripheral. So I think radiation immunitis may not be that much problem.
Okay, yeah, that is also a school of thought. True. Sir, see, I put. Sir.
Study was very clear that before giving, once the regimen was over, they scanned MRI. If the MRI was not showing a disease, they gave PCR. There was no difference. A patient who is going to take durvalumab will be affording MRI also.
True. So the final verdict on this, sir will give.
Nearly all are going to come up with a metastasis
True,
in the
sir.
brain. There's no question about it. The Japanese study changed the outlook from USA, majority of not doing brain RT now, because they are confident that patients will have come for regular MRI screening. If we have that same facility, they are going to come for regular screening MRI, you may not give an MRI, may not give a brain RT. That's what I as a radiation oncologist practice in my setup.
So, with all these conflicting data, PCI might be beneficial, although it is on physician's judgment. So, I think it will be a case-to-case driven. I think a tumor MTD will be the only answer to this. Similarly, there is a paucity of data on these. Thoracic RT, again, personally speaking, sir.
Thoracic RT in a liver met, in a patient with a liver.
Sir, patient has now got us a complete response.
Okay.
Now.
This I do not know, but what is the data from the CREST, the data, Slotman's data, in the presence of the liver, no use. When there is a liver met, thoracic RT has not helped.
So the only data which has come out of these trials is that greatest benefit of thoracic RT is limited to patients with residual thoracic disease after systemic therapy with less than 2 metastases. So lots of disease, no benefit. In an oligometastatic kind of disease only, you have some benefit. So these benefits are very, very limited. Again, a physician's discretion, because we are too young in immunotherapy and we'll take a lot of time to see the benefit of these things. So patient is on metastasis, is on maintenance, and I think I'll just wind up on this so that we can go ahead on the next session. Thank you, everyone. Thank you to the esteemed panelists for a wonderful discussion. Thank you, everyone.